Mic on? Sound good? Yes. Pretty good? Sounds terrible. The worst you've ever heard. All right, so my name is Schillerstrom. I'm a geriatric psychiatrist at the University of Texas Health Science Center in San Antonio. I'm faculty with Dr. Salazar. They're just today, I retitled my talk. Joe loves it when I do this. He loves it when I retitle my talk and just pull something out of the air. He loves that. And so, instead of like dementia treatments in South Texas, I changed it to actually what I do much more of, which is decisional capacity assessments in South Texas. So that's what we're going to talk about. Normally a disclosure slide would follow, and man, I totally failed to do the disclosure slide. That's my oversight. The only disclosure that I have would be that that my department contracts my services out to Adult Protective Services to do decision-making capacity assessments for them. So that's the only thing I would disclose, is that I do decision-making capacity assessments for Adult Protective Services as a function of my job through UT. And so we are in Region 8. Texas Adult Protective Services is divided up into 11 different regions, and we are in Region 8. Region 8 has 28 Texas counties in it. And so every Wednesday, Adult Protective Services picks me up, and away we go into South Texas to stamp out decisional incapacity. Right? That's what we do. We stamp it. Someone laughed. You don't think that's what we do? Okay. Well, we identify it, but we don't stamp it out. We identify decisional incapacity. So when I do these assessments for Adult Protective Services, APS wants to know. The first thing they want to know is, does the client have decision-making capacity? The second thing they want to know is what level of care do they need? They want to know, do they have a psychiatric diagnosis? And then the other thing they want to know is this situation so dire? Are things so imminently dangerous that that my medical opinion would be to remove this client today and have them medically cleared, place in a supervised setting until the judicial system can sort out the need for guardianship. So those are the questions that Adult Protective Services is hoping that I'll be able to answer for them. So all of the assessments I do, they're all in-home visits. Almost all of them are in-home visits across this region. And so to start with. Okay, so this is Texas's legal definition of incapacity. So an incapacitated person is an adult who, because of a physical or mental condition, is substantially unable to provide food, clothing, or shelter for himself or herself, to care for the individual's own physical health, or to manage the individual's own financial affairs. And so because of this conference, which is whoever came up with the idea for this conference, that was a wonderful idea. This is a great idea. And so because the conference is focused on Hispanics and kind of has a sort of a cultural theme, if you will, I guess my question to the group is, this is Texas law right here, but through a sort of a Hispanic lens, are there any, does the group detect any kind of cultural issues or cultural concerns related to this law? Or do you think it transcends culture?
No.
It doesn't transcend culture.
Because in the minority community, family members are very dependent upon each other.
So what was stated, just so I'll use the mic to echo what you said. So what was stated is that many times in the minority community, that family members are very dependent on each other. Okay.
And family members may not look at that law under the same lens that we may look at it.
Okay.
They might not have a problem with it.
Okay.
Whereas we're trying to talk to them and tell them it's a problem with this.
Mm-hmm. Can you,
sometimes it can.
you know, I think you're absolutely right. Can you give some examples of culturally acceptable dependents?
Bobby's at home taking care of mama who's got cancer, and Bobby may not have a mental IQ level of, above 80 or something like that.
Sure.
But he knows how to take care of the grandmother. He knows how to make sure she's eating. He's there doing all of this while the other one is out working and making the money to pay the light bill and do everything. And then he goes to the doctor with the grandmother or the grandpa or whoever. And then we're the professionals sitting in there and we see this and we get horrified. Oh, he's at home taking care of her. You know, he got an IQ level below this or that.
Yeah.
But for that family, he's that trusted family member. So grandma may not have the capacity, and he may not have the capacity, and it can cause a big problem, and grandma can get removed.
Yeah, I think we see that all the time. And then the grandmother gets removed, and then the family's dependent on her Social Security income check. And now what happens to the son who has perhaps borderline intellectual functioning, and it can just really get sticky, right? It can really get sticky. So I think you're right. I mean, one of the things this suggests is that we're all autonomous, right? We're all autonomous. And, but I do hear what you're saying with, within, the family could be autonomous, but maybe individuals within the family are not. And maybe as a collective family they get the job done, but they're not. Yeah, one of the challenges with capacity assessments is that, there's lots of challenges, but one of the challenges is this, first is the assumption that we're all autonomous, which I think everybody would generally agree with that. And then we are evaluating individuals. So for adult protective services to get involved in your life, you had to make yourself known, right? So there's lots of people who may not have capacity, but in some way you did something where somebody noticed you, became concerned, and filed a report, right? You made yourself known. And so I think that's the challenge also. And so there's lots of families, I think exactly like you're describing, that function day to day fine. They just don't make themselves known, right? They just don't make themselves known. So I think that's true. Good, very good. So one of the things, so what I'm going to do is what I've done is I've taken data from 2008, between 2008 and 2011, I have an APS data set that is 233 consecutive capacity referrals. And so what I did was I took this data set yesterday and I just kind of broke it down into comparing Hispanics and white people, right? And I know that there's ethnicity and there's race and there's differences between the two, but just for simplicity, which may not be the best way to do it, that's what I'm comparing, right? I'm just comparing kind of Hispanics with whites within this APS data set. So the first thing that you'll see when you look at my 233 subjects, of the 233 subjects that were referred to me for a capacity assessment between 2008 and 2011, 21% of them were Hispanic, and 73% were white. This is the ethnicity race breakdown of what APS asked me to help them with. So 21% of the capacity assessments that I saw in this 28-county South Texas region were Hispanic. 21%. So what do y'all make of that? Does that seem right? About 21% in South Texas would be Hispanic? No? You think it should be lower, right? It should probably be lower. That's probably overrepresented. You think Hispanics are overrepresented in this sample? No, you think they're underrepresented. So you think Hispanics might be underrepresented in this. It's got to be higher. It's got to be higher. And again, this is not a sample of consecutive APS cases. This is a sample of consecutive APS cases that they referred to me, right? That they referred to me. You know, and the truth is, when I saw that number, I thought, man, that can't be right. That's just so low. It's only 21%. That's low, right? But then, let's see here. Right? So this right here is all of Texas. I just pulled this off of the Adult Protective Services, or I'm sorry, Department of Family and Protective Services data thing. It's a PDF. You can get it. Just Google DFPS, APS data, and this will pop up. And so within all of Texas, let me see if I can find this right here. All of Texas, the Hispanic, 22%, when you add up the validated APS cases in all of Texas, 22% of APS cases in all of Texas are Hispanic. 22%. So the truth is that the 21% that I'm being referred is actually right there with at least the state norm, if you will, right? And so in all of Texas, 52% got it. Does it create this Texas flag? So in all of Texas, 52% of validated APS cases are Anglo, 21% are African American, and 22% are Hispanic, right? So actually, the Hispanics statewide, actually that number mirrors what I'm being referred. So when I saw the number, I thought, wow, that's low. But then I saw the state data, I thought, well, maybe not. I don't know. You know what's clearly low then is blacks, right? At 5%. That's clearly low. So you want to know who I'm not being referred? It's actually African American clients. That's who I'm missing in South Texas. So I don't know. Any thoughts on that?
I just had a thought. It would be interesting to compare this area age and the actual population demographics, because I would think that the percentage of Hispanics in area A of the whole population is probably a little higher than most of the state.
Yeah.
Which would mean that they're underrepresented, still underrepresented.
Yeah, that could be. It could be underrepresented for the region, but not for the state. That's possible. That's very possible. And I don't have that data. I don't know the answer to it, but I do think it's a very thoughtful hypothesis.
Yeah, it'd just be interesting to me to see that data.
So then what we do is we compared, what I did was I compared gender differences and kind of rural dwelling, squalor dwelling. Did they have capacity? Did they not? And were they emergently removed? So between Hispanics and whites, do you think there's going to be gender differences? Or no differences? No? Between Hispanic and whites, are there going to be are there going to be differences in the distribution of rural dwelling clients? Probably, maybe. Okay, yeah. So if we kind of look at these, there's no differences between. If you look at the clients, I'm doing terrible with this thing. Okay, so about 60% of the clients I see are this is gender, should be women. So about 60% are women. And that's equal between Hispanics and whites that I see. Without a doubt, more of the Anglo or white clients that I see live in the rural areas. And rural areas was defined as living in a county with less than 50,000 people, right? So, yeah. When you look at recidivistic cases, there's no difference between Hispanics and whites. When you look at squalor dwelling, and squalor dwelling, I always have to define squalor dwelling. If you work for Adult Protective Services, you know exactly what I mean. Right? Right? If you don't work for Adult Protective Services, use your imagination and you're probably right. Okay? So I do think the inter-rater reliability of measuring squalor dwelling behavior would be high. So no differences in the number of squalor dwellers. When you look at the percent that I in my medical opinion, deemed to be incapacitated, about 94% of Hispanics, I don't think, that are referred to me, I don't think have capacity. About 90% of Anglos or whites, I don't think have capacity of the group that's referred to me by APS. And when you look at emergency removals, about 20% of Hispanics I'm recommending for an emergency removal, and about 13% of whites I'm recommending for an emergency removal. There's a difference there, but it doesn't pan out statistically. Statistically, the only difference was between rural and urban. That's it. That's it. So I'm more likely to see Hispanics in San Antonio, Victoria, New Braunfels, or Comal County, and I think Carr County was the other one. So I think Del Rio, maybe Del Rio. So those are really the only differences. We do neuropsychiatric batteries. When we do these capacity assessments, we measure their memory, their general cognition, executive function, visual spatial abilities, and we always screen for depression. We don't want to miss depression, right? Depression's so easy to treat. We wouldn't want to declare someone to be incapacitated when all they need is some help for depression. Do you think there's any cognitive differences between Hispanics and whites in this sample? Any cognitive differences? Do you think they perform better or worse or the same on cognitive testing? Yeah, not the same actually. Yeah, when you look at the differences, when you look at the comparisons, the only differences are, there's the memory impairment screen. Hispanics are more likely to fail the memory impairment screen. They're also more likely to fail CLOCKS 2, and Dr. Salazar is going to go over that in the next hour. In fact, the CLOCKS 2 is what you have in front of you. That was just passed out. It's that clock drawing task, and that's what Dr. Salazar will be going over next. To make a long story short, CLOCKS 2, as he will describe, is simply your ability to look at a clock and copy it. That's all it is. It's just looking at a clock and copying it. Right? And looking at something and just copying it is right parietal cortex. You're exercising your posterior part of your right hemisphere. So the only cognitive differences between these two were the memory impairment screen and CLOCKS 2. Memory impairment screen is interesting because that's a very verbal task. What I do is I show the clients 4 words. I ask them to read those 4 words and remember those 4 words. And then I distract them, and then later on I ask them what were those 4 words. Well, you know, almost all the clients that I see are English speaking, but nonetheless, given that this is such a verbal task, there is a part of me that wonders if that memory impairment screen could be influenced by language, if you will, given its highly verbal nature, right? They're like reading these 4 words. So maybe that might explain why some of them do more poorly. I don't know. Let's see here. For CLOCKS 2, though, on the CLOCKS 2, what's interesting about CLOCKS 2, those of you that have heard me talk before know, so I just ask you, what cognition predicts self-care ability? Don't let me down. Come on. What cognition predicts a person's ability to care for themselves? Is it knowing the date? No. Is it memory? No. What is it?
Motor.
No, not motor, but that's a good guess. What else? What is it? Executive function, right? You've heard me talk, you know executive function, executive function, executive function. Your ability to solve problems independently from habits and routines is what predicts your ability to care for yourself independently. It's executive function. The executive function doesn't predict survival. What predicts survival? So here what we did was we took our APS sample, we decided we wanted to learn who dies after a year and a half that I see them. And what predicts it? What predicts mortality, right? APS is trying to keep people from dying, right? That's not totally their mission, but that's kind of one of the sort of the unstated things, is to keep them from dying, right? Way to go, y'all. Okay, so if you look at 18 months survival from the time I see him 18 months out, what you'll see is, what predicts survival neurocognitively is your ability to copy a clock. So if you can't look at a clock and copy it accurately, 25% will be dead within 18 months. That's what this says, right? 25% of the clients that I see who can't look at a clock and copy it accurately will be dead in 18 months, compared to about, what is that? That's about 90-something% of those who could copy a clock, right? So what predicts survival neurocognitively is your ability to look at a clock and copy it accurately. So now I'm setting up Ricardo's next hour. Now all of you are saying, damn it, I'm going to learn how to copy a clock. Dr. Salazar is going to save all of you from 18-month mortality in 30 minutes by teaching you how to stay alive by copying a clock. It's going to be awesome. You're going to pay attention. Okay, so again, when you look at the Hispanic group, that's the one thing that they do worse, right? That's the one thing that they do worse than what it's actually is copying a clock. And so as we start to think about kind of differences in Hispanics versus other ethnicities or races, I do think that's kind of an interesting neuropsychological finding right there, and one that may forebode a poor outcome, in fact. What I want to do next is just go over what we're going to do real quick. We're going to go over a case. I'm going to give you just a typical case. We'll see what type of discussion you have, and then we should finish right at 11:30. So we're going to be good. Okay. So this is an APS case. This is a recidivistic case. It was an 88-year-old Hispanic woman who was referred to me for neglect. She lives in San Antonio. And then Adult Protective Services on the car ride over, they're giving me all sorts of good information, and they're saying, well, you know, the reason we got involved in this case is her house is in terrible shape. She's living in squalor, there's animal feces throughout, there's human waste in the toilet and bathtub, the toilet doesn't look like it's working, there's insect infestation, and I think a family member recently discovered a dead dog in the home. So this is like a squalor home. Severe insect infestation. I always know it's going to be a bad day when the APS worker hands me a can of Raid. Right? That's a bad day. Right? Sonia knows. She's had Raid before. Okay, so this is going to be. So this is like a really bad one. Okay. The primary care doctor knows the patient. I've been following the patient for quite a while, in fact. It's not a new primary care doctor. And the primary care doctor told APS that he thinks she probably has capacity. And the exact quotes were that, well, you know, she misses her appointments, but she takes her medications. She has bad hygiene, but she has capacity. She has bad hygiene, but she has capacity. So what do you make of those two statements? Yeah.
How does he know she's taking her meds?
Yeah, how does she know she's taking her meds, right? You know, and I can tell you, this is, so one of the things, I have to be careful here. So, I have to be careful. This is like, man, this is like thin ice for like a, I feel like Olaf, the white snowman. But I will say that when doing these capacity assessments, I do, while we do respect culture, I do think it's important to hold the community to some standard, and not to say that, well, you know, she's a little dirty. But I don't like to do that. So when I hear that she has bad hygiene or whatever, I don't think that that's a reason to. I don't think culture is sufficient to explain bad hygiene. I guess that's what I'm trying to say. So the family seems to either underestimate the health or safety hazards, or they seem to overestimate the client's ability. So this goes back to what was said in the back room there about kind of families and what they think. So for example, she's living in these terrible conditions, and 4 days before I saw her, they brought her a broom. Right? They brought the client a broom. They said, here, see if you can sweep up a little. Right? The utilities are frequently disconnected. APS and the family have had them paid and reconnected multiple times on multiple occasions. Past psych history, medication, pretty much all of this is sort of unknown to me at the time that I was doing the assessment. If you look at the client's social history, she has a 4-year sociology degree from San Antonio. She doesn't have any children of her own, but she has stepchildren. She's not drinking, not smoking. She earns $550 a month, and she receives Meals on Wheels. Kind of, another cultural thing that'll come up, and this happens when I'm talking to attorneys, right? This happens when I'm talking to attorneys. It's kind of a cultural thing. Is they'll say things like, Dr. Schillerstrom, don't you agree that that the more financial assets you have, the more capacity it takes to manage those resources? And I understand what they're saying. I understand that it's, managing large sums of wealth is hard. But my response to those attorneys is always the same. It's always, you tell me what takes more brain power. Does it take more brain power living off of $5,000 a month or living off of $500 a month? Right? And that tends to nip that question. Right? But, so that might be kind of a cultural thing. Right? And I don't mean to pick on attorneys. I love attorneys. But that's the question that I get from attorneys who are generally trying to figure out how to manage all these large estate type issues. As I see Lisa sitting here at the front row.
I think I'm the only one here.
You're the only one here. Lisa's the only attorney here. So okay, that's what I say. Okay. If you look at her home, I'm sorry, you might not be able to see these in the light, but just trust me that this room is filthy. It has animal feces on the floor. That's her mattress right there. You wouldn't want your dog to sleep on that mattress, much less an 88-year-old woman. This is her refrigerator. Unfortunately, in a slide, you cannot smell the refrigerator. Just trust me. There's all these bugs flying around at the bottom down there. There's all this rotten food. If you look at this is like the toilet. One day I told somebody, I'm gonna have a collage. It's gonna be titled "Toilets of South Texas." Anyway, just try this toilet is like overflowing. It's a mess. And then all of that is like used toilet paper and feces that's just kind of sitting there in her bathtub. So the house really is not good. When we test her out, she's got a little bit of depression, about a 6. That's a little bit high on the depression scale. Her memory's not terrible. It's promptable. She has memory impairments, but they're promptable. For those of you familiar with the Mini-Mental, she gets an 18 out of 30 on the Mini-Mental, so she's scoring below the cut point, which would be a 24 below. She fails clock drawing, she fails clocks 2, and her exit is a 28 out of 50. So her frontal lobe functioning approximates that of a 4-year-old. Just to give you an idea, her frontal lobe functioning, her ability to solve problems. When you think about 4-year-olds though, 4-year-olds can do a lot, right? Like, they can walk, they can talk, they can, what else can 4-year-olds do? They can feed themselves, right? If it's given to them. But can they prepare meals? Can they do housekeeping? Can they manage their finances? Can they provide safe food, clothing, and shelter, manage their healthcare needs, and care for and manage their finances? Can they do that? No, right? They're incapacitated. So this is one of the cases I saw. This was a case that I saw on the west side, I think, here in San Antonio. So what do y'all think? Do you think this lady has capacity? No? Yeah. So one of the things that APS can do is they can offer the client like a heavy clean. They can come in and they can like clean out this house. What would you predict would happen if they did that? Yeah, right? Like I clean out my 4-year-old's bedroom. Does it stay that way? No, I gotta do it like every week. I'm like, What can we predict about her abilities to manage her healthcare needs? Is she going to be able to do that? No. All right. What about her ability to manage her finances? So what APS can do is they can zero balance that electric bill or water bill. They can pay it off, close the case, and move on. They can do that. What do you think would happen if they did that? It's just going to build up again. Okay. So she doesn't have the capacity. What about her mortality? What can we predict about her mortality? Right. She's not looking good. I don't know what she's going to look like 18 months from now, but it probably won't be good. And so what should we do? So we have this elderly Hispanic woman. She's in this home. It looks like that. She has the frontal lobe functioning of about a 4-year-old. What should we do? What? What's that? Well, no, so the suggestion was involve family. Keep in mind, family brought her a broom. What should we do?
Home health care service.
Yeah, so so this is an example of a removal. So this is a lady that we would remove. This is an example of a case where she's just living in deplorable conditions. She's very cognitively impaired. In my eyes, this is a disaster waiting to happen. In my eyes, she's in imminent danger. She continues to live like this. So this is the type of case that I would recommend that APS petition the courts to do an emergency removal. This is that type of case. So, okay. So let's see here. Man, look at that. Time to spare. All right. So, any questions about this? Yeah.
Is it possible, because I work for CPS, not APS, but is it possible to clean the house and then have some type of nursing or home health care service that comes out and does the cleaning, the cooking for her, and kind of pretty much there at all times to watch her instead of removing her from the home?
Well, that's a good question. So that's a very good question. So the question was, is it possible to basically clean up the house, get the bills paid, and then have the client remain in her home, but have like provider support or home health support? And that is, it is possible. What I can tell you is that, because APS wants to know what level of care this person needs, and what I would say for a person like this who's not meeting their instrumental activities of daily living, she's also not meeting her basic activities of daily living. She's not bathing, she's not grooming, there is evidence of incontinence, that kind of thing. So my recommendation to APS, it's just a recommendation, is that she needs 24-hour supervision and a nursing home level of care. And if she has the financial resources to provide that in her own home, then that is clearly the least restrictive placement. I can tell you, for a client with $550 a month income,
And may I piggyback on that?
yeah.
I've seen that scenario many times, and when you're working with the home health agency, they're not going to send their people into an unsafe, unsanitary condition.
That's a good point.
And even when APS has gone in, quote, quote, and cleaned it up, you've got a provider that's got to deal with a person they have to respect, because when they go there and that person say, I don't want a bath, no, don't touch this, no, don't touch that, those providers have been trained. You are in their home. This is not your home. You can't take that over. So then you've got the agency calling the people back like us. Oh, we're not going to send anybody else over there. Yeah, we send them over there. She won't let them touch this. She won't let them touch that. It's a major problem. We just have to discontinue that service because
Yeah, so that's a very good point, is that you can't put home health care or providers into a dangerous home, and that the providers have to respect the autonomy of the elder. And so then there is kind of how agreeable are they going to be. And that happens a lot. I mean, usually by the time APS refers the case to me, in fact, every time after they refer the case to me, the client has, they've refused the least restrictive services. So, Region 8 gets whatever, 20,000, probably about 15,000 calls per year, something like that, right? About, maybe, yeah. And I'm only seeing about 75 of their cases. So by the time a client makes it to me, APS has worked incredibly hard to get them to accept these least restrictive interventions that you're suggesting. And it just hasn't worked out. And now it's time to do a capacity assessment and either pursue guardianship, think about pursuing guardianship, or declare them to have capacity, in which case they can continue to offer resources, but then close the case and move on. Any other questions? Yeah.
I actually work with APS out in Medina County, and so I work, the rural area and that kind of thing. So with my clients, as you're talking, I'm already thinking about all the cases where, my clients either do.
I'll see you on Wednesday. That'll be great. I love Medina County.
Yeah, come out there. We have plenty going on. And so on the health assessments that I've sat in on, my question is that, I worked with actually Dr. Morales, and while he's administering the assessment, I'm just thinking to myself, based on what the family has told me about behaviors, the personality of the client and that kind of thing, they've always been stubborn, they've always had bad hygiene, their home has always been this way. I'm just curious, how can y'all differentiate
how to reconcile
the lack of capacity versus just this is the way they've always been?
Yeah, no, that's an excellent question, because I'll hear that too. I'll say, oh, he's always looked like that. Really? So, okay. Yeah, no, I'll hear that too. So what we have to decide is this person now exercising choice? So we have to decide, are they living this way because they choose to live this way? Or are they living this way because now they're confined by their habits and their routines, and because they're so captured by habit and routine, they can no longer choose to live any other way, right? And so now the cognitive testing becomes super important, because once people become executively impaired, once they become frontally impaired, they can no longer live outside of their habits and their routines. They're now trapped by those. And so that becomes kind of the cut point, is if they have clinically significant executive deficits, it means they're trapped by this lifestyle. Whereas if they're executively fine, then it means that they're continuing to just choose to live the dirty life they've always lived. So that's where the cognitive testing really helps. That's where it makes a big difference. And I think also culturally, and this isn't about being Hispanic or any other race or ethnicity. It's that it has to do just with poverty, right? It's poverty enters the equation, and being poor is not the same as being incapacitated. And so as we're doing these assessments, we're always just very mindful of that. What resources do they have? What resources can be provided to augment what they have that may allow them to remain autonomous? And so I think that's the other challenge, which on one hand, the in-home assessments, I do think that's the best way to do it. On the other hand, it's hard. I can tell you just personally, it's hard to not be biased by that. It's hard to be in a home valued at $20,000 and see it falling apart and not be biased by that. That's tough. So we have to just exercise our own frontal lobes to do that. Yeah?
I was just going to, since Eric brought up Dr. Morales, I was thinking that maybe, or actually Lisa and I were thinking that maybe the numbers are low for the Hispanics that you're assessing, because Dr. Morales isn't associated with the medical school. However, he also contracts with us, and he has been trained by Dr. Schillerstrom, and he actually does the Hispanic population that we serve that are Spanish speakers.
That's right. But this data is from 2008 to 2011.
Yeah, I don't remember what
He hasn't been with y'all since 2011. It's been not 2013 or so, 12 or 13.
So we
Yeah.
could also
But you're right, right?
check out,
Thank God for Dr. Morales.
Yes.
Right.
And before that, that's true, Dr. Salazar actually did a lot of our
That's right.
Spanish speakers.
That's right.
So,
Could
I just,
also the
since you
fact-
brought it up, I wanted to throw it out there.
Could also the fact that we categorize the Hispanics as being white in the.
No, he's doing different, he's pulling from his statistics, not how we do it here.
Yeah, right. So like demographically, you have non-Hispanic, white, Hispanic, white. So there's race and ethnicity, and this is just sort of my trying to show you the Hispanics, show you the demographic and cognitive profiles of the Hispanics that I serve. All right, I'm going to step away. I think Dr. Salazar is going to teach you how to copy a clock so that you don't die. All right. Thank y'all.